Welcome to Dr. Balga's podcast for the Curious Doc. Today is February 24th, 2026. This video is on a Lancet article published in its February 21st issue titled Tenecteplase versus Standard Medical Treatment for Basilar Artery Occlusion within 24 hours, the TRACE-5 study. It's a multi-center, prospective, randomized, open-label, blinded endpoint superiority phase 3 trial. There was an accompanying commentary titled Intravenous Tenecteplase for Acute Ischemic Stroke within 24 hours due to basilar artery occlusion. Basilar artery occlusion is a devastating posterior circulation large vessel occlusion with mortality up to 80 to 90% without recanalization. Endovascular thrombectomy is effective within 24 hours, but global access is limited. Tenecteplase is a genetically modified tissue plasminogen activator, TPA, with higher fibrin specificity and longer half-life than alteplase. No phase 3 trial evaluated tenecteplase within 24 hours specifically for basilar artery occlusion. The study was a multi-center, prospective, randomized, open-label, blinded endpoint superiority phase 3 trial with the acronym TRACE-5. 66 stroke centers in China participated. There were 452 patients enrolled. 221 received tenecteplase and 231 received standard medical treatment. Mean age of the cohort was 66.4 years. 71% were male. The median NIH stroke scale score was 12. Time to randomization, median was 6.4 hours, included wake-up strokes. Intervention, tenecteplase 0.25 milligrams per kilo, maximum 25 milligrams. Single IV bolus dose within 24 hours. The control group was standard medical treatment, including alteplase within 4 to 5 hours, anticoagulation or antiplatelets. Thrombectomy is allowed. The primary outcome was a modified Rankin scale of 0 to 1 or return to baseline at 90 days. Statistics modified Poisson regression adjusted for age, baseline NIH stroke scale score, and onset to randomization time. Power 80% to detect 12% absolute difference. Follow-up for 90 days. What did they find? The primary outcome was achieved in 38% of the treated group versus 29% in the control group. P-value equals to 0.014. Ordinal shift analysis, the common odds ratio is 1.51. P-value is equal to 0.022. The modified Rankin scale of 0 to 2, p-value equals 0.29. Modified Rankin scale of 0 to 3, p-value 0.66. Substantial reperfusion before thrombectomy, 24% in the treated group versus 13% in the control group, p-value 0.038. Symptomatic intracranial hemorrhage, 2% in the treated group versus 3% in the control group, p-value 0.39. 90-day mortality was 29% in the treated group versus 31% in the control group, p-value 0.41. The modified Rankin scale of 5 to 6 was 37% in the treated group versus 39% in the control group, p-value 0.38. Limitations of the study, open-label design, restricted to Chinese population with high intracranial atherosclerosis prevalence. Limited thrombectomy uptake, less than 50%. It was about 49% overall. Biosimilar tenecteplase formulation. It was not powered for thrombectomy intended subgroup. Key takeaways. Single bolus tenecteplase within 24 hours improves excellent functional outcome. Safety comparable to standard medical therapy. Pragmatic imaging strategy enhances global feasibility. Supports guideline reconsideration pending external validation. What do the accompanying editorials say? Or the commentary confirms phase 3 evidence supporting tenecteplase within 24 hours. The benefits are consistent across age. severity of stroke, imaging modality, and use of alteplase. Half of the eligible severe strokes did not undergo thrombectomy, often due to cost. No crude post hoc superiority across all endpoints. Substantial intercenter recruitment variability. These findings potentially practice changing if confirmed in non-Asian cohorts. Clinical pearls. Basilar artery occlusion carries catastrophic prognosis without reperfusion. Tenecteplase simplifies logistics, single bolus, no infusion pump. Posterior circulation stroke may have lower hemorrhagic risks than anterior circulation. Benefits seen even in patients not undergoing thrombectomy. Advanced perfusion imaging not mandatory for late window selection. Bridging thrombolysis may enhance prothrombectomy reperfusion. These are some eponyms and historical anchors. Hit pause and read at your leisure. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.